in my last lecture, I classified the thyroid inhibitors, and these are drugs that inhibit the synthesis of thyroid hormones, and the drugs are propylthiouracil, methimazole and carbimazole. Also, we have drugs that inhibit the release of thyroid hormones, and the drugs are iodides. So, iodides inhibit the release of thyroid hormone. And also the drugs such as radioactive iodine or iodine 131 causes destruction of the thyroid gland and helps to reduce the thyroid hormone levels and control hyperthyroidism. In this lecture, I am going to explain the therapeutic uses and adverse effects of propylthiouracil and compare with other drugs belonging to the same class, that is methimazole and carbimazole. Now, before discussing the therapeutic uses of thioamides, let us see how do these drugs act. Thioamides such as propylthiouracil acts by inhibiting thyroid peroxidase enzyme, which catalyzes different steps of thyroid hormone synthesis. The steps are oxidation, where iodide is converted to iodine. Iodine then combines with tyrosine residues to form iodo-tyrosine residues, and subsequently iodo-tyrosine residues couple together to form T3 and T4. So monoiodotyrosine combines with diiodotyrosine to form T3, and two diiodotyrosine residues combine to form T4 hormones. So oxidation and coupling are responsible for thyroid hormone synthesis, and the enzyme that is responsible that catalyzes these steps is thyroid peroxidase enzyme. And propylthiouracil, by inhibiting thyroid peroxidase enzyme, inhibits oxidation, inhibits coupling, thereby inhibiting the synthesis of thyroid hormones, decreasing the thyroid hormone levels, and help in controlling the symptoms of hyperthyroidism. It is important to note that with these drugs, a reduction in thyroid hormones is seen after a period of 3 to 4 weeks compared to iodides, where an immediate action is seen and there is an immediate reduction in thyroid hormone levels. This is because the preformed thyroid hormones that are synthesized and stored in the follicles are released into the circulation. So immediate reduction in thyroid hormone levels is not seen with these drugs, and despite inhibition of the enzyme, that is thyroid peroxidase enzyme, the T3, T4 levels are still raised, and a reduction is seen only after 3 to 4 weeks. Also, do remember that propylthiouracil has an additional property of inhibiting the peripheral conversion of T4 to T3, which is the active form of thyroid hormone. So, this property is absent with methimazole or carbimazole, and also propylthiouracil is more rapid acting compared to carbimazole or methimazole. So, propylthiouracil has better effectiveness, is more effective in reducing T3, T4 levels in the plasma, and also it is more rapid acting, and therefore propylthiouracil is preferred in an acute setting such as thyroid storm, thyrotoxic crisis. So now that you're familiar with the mechanism of action of thioamide class of drugs, let's discuss the therapeutic uses of thioamide. The first indication is Graves' disease. So this is also known as diffuse toxic goiter. It's the most common form of hyperthyroidism. It is an autoimmune disease, and it is characterized by the formation of antibodies. Autoantibodies are formed, which is also known as thyroid stimulating immunoglobulin. So TSI stands for thyroid stimulating immunoglobulin, and it mimics thyroid stimulating hormone, which is secreted by the anterior pituitary. So thyroid stimulating immunoglobulin mimics thyroid stimulating hormone. When compared to thyroid stimulating hormone, this immunoglobulin or this antibody is a long acting thyroid stimulator. It's a long acting thyroid stimulator, which means that it continuously stimulates the thyroid gland, resulting in excessive formation of T3, T4 releasing into the circulation, and is responsible for hyperthyroidism and thyrotoxicosis. So, autoimmune process, production of thyroid stimulating immunoglobulins, continuous stimulation of thyroid gland, resulting in hyperthyroidism or thyrotoxicosis. So, this causes symptoms of hyperthyroidism, but the classic finding of Graves' disease is that exophthalmos or lid retraction, periorbital edema, also pretibial lymphedema Graves' disease where there is a localized thickening of the skin on the shin. So red thickened skin on the shin, which is known as pretibial myxedema. So exophthalmos, pretibial myxedema, these are some of the characteristic features of Graves' disease. The diagnosis is confirmed by high T3, T4 levels, low TSH, increased radioactive iodine uptake because the thyroid gland is hyperactive, there is increased radioactive iodine uptake, and also presence of thyroid stimulating immunoglobulins in the circulation. So these are some of the diagnostic features of Graves' disease. Let's now discuss the treatment options of Graves' disease. The treatment options in Graves' disease are thioamides, which includes drugs such as propylthiouracil, methimazole and carbimazole. The next treatment option is radioactive iodine or iodine 131, and the third treatment option is surgical ablation of thyroid gland or subtotal thyroidectomy. Now amongst these treatment options, thioamides is the preferred treatment in a young patient with small goiter. So mild to moderate disease and the patient is young, thioamides is the preferred treatment choice. This is because there is less surgical risk, less risk of injury to the parathyroid gland, the recurrent laryngeal nerve, and also this is the only treatment where the thyroid gland is intact. So hypothyroidism, if induced, is reversible. This is not possible with radioactive iodine treatment which destroys the thyroid gland. Surgical removal of the thyroid gland induces permanent hypothyroidism. Therefore, thioamides is the preferred treatment of choice in a young patient with short history of Graves' disease, mild to moderate disease. So next is how to select an appropriate thioamide for the treatment of mild to moderate Graves' disease. Methimazole, when compared to propylthiouracil, has a longer duration of action because it has a longer T-half. Single daily dosing is required, and with respect to the safety profile, methimazole has lesser side effects compared to propylthiouracil. Therefore, methimazole is preferred over propylthiouracil for the treatment of mild to moderate Graves' disease. But in case of severe Graves' disease, radioactive iodine treatment and surgical ablation of thyroid gland are treatments of choice in severe Graves' disease. The next indication of thioamides is toxic nodular goiter. This condition is characterized by autonomously functioning nodules producing excessive T3, T4 secretion leading to hyperthyroidism or thyrotoxicosis. It is of two types: toxic multinodular goiter and toxic adenoma. Toxic multinodular goiter is characterized by multiple nodules that are autonomously functioning producing excessive T3 and T4 levels, whereas toxic adenoma is characterized by solitary nodules, solitary hyperactive nodules. Now when it comes to the role of thioamides, they have limited effectiveness in the management of toxic nodular goiter, and the definitive treatments in this condition is radioactive iodine treatment and subtotal thyroidectomy. Thioamides are less effective in toxic nodular goiter compared to its role in Graves' disease. They have limited effectiveness, and definitive treatments are radioactive iodine treatment and surgery. Now the next indication is thyrotoxicosis and pregnancy. So thyrotoxicosis can also occur in a pregnant woman, and let's look at the treatment options. So thyroid surgery in a pregnant woman increases the risk of miscarriage, whereas radioactive iodine treatment increases the risk of fetal goiter. So fetal goiter can occur with radioactive iodine treatment, exposure to radiation, and surgery increases the risk of miscarriage. Therefore, preferred treatment in a pregnant woman with thyrotoxicosis is thioamides. So thioamides are preferred in a pregnant woman with thyrotoxicosis. Now amongst the drugs that are included under thioamides are propylthiouracil, methimazole and carbimazole. To be noted that methimazole is known to be associated with congenital defects such as aplasia cutis and esophageal atresia. So esophageal atresia and aplasia cutis, which means that the skin is absent. So these are congenital malformations that are associated with methimazole, carbimazole, and therefore they should be avoided in the first trimester of pregnancy when organ formation of the fetus occurs, and this is the period, that is the first trimester of pregnancy, where propylthiouracil is the drug of choice because it has high plasma protein binding affinity and less drug crosses the placenta and affects the fetus. Whereas methimazole is lipid soluble drug, it easily crosses the placenta, large amount of drug crosses the placenta and affects the fetus and causes congenital malformation. But do remember that propylthiouracil is associated with side effects such as hepatitis, agranulocytosis, and methimazole is relatively safer with respect to these side effects. Therefore, the patient can be shifted from propylthiouracil to methimazole in the second and third trimester of pregnancy. So, first trimester pregnancy, propylthiouracil is the preferred treatment. Second and third trimester, methimazole can be used in a pregnant woman that is suffering from thyrotoxicosis. The next indication of thiamides is that they can be used pre-operatively, that is prior to surgery, and they can also be used prior to radioactive iodine treatment. This is done to stabilize a thyrotoxic patient and to achieve euthyroidism. So why is euthyroidism necessary before surgery and before radioactive iodine treatment? Firstly, euthyroidism helps to stabilize the thyrotoxic patient and prevents thyroid storm or thyrotoxic crisis, because sudden manipulation of the thyroid gland during surgery causes excessive release of thyroid hormones into the circulation, and this results in thyroid storm. So euthyroidism prevents, reduces the incidence of thyroid storm. Secondly, there is reduced cardiovascular risk. This is because a hyperthyroid patient can have tachycardia, hypertension, arrhythmias, and making the patient euthyroid stabilizing patient minimizes the risk of perioperative cardiac complication and makes surgery more effective and safer. Also, euthyroidism is associated with better surgical outcomes. This is because a highly vascularized thyroid gland increases the risk of intraoperative bleeding, increased risk of complications such as neck hematoma formation, difficulty in hemostasis, increased risk of bleeding during surgery. A small and less vascular thyroid gland improves the surgical outcomes, and therefore euthyroidism is necessary before surgery. Also, euthyroidism is essential prior to radioactive iodine treatment because it decreases the radio resistance of the thyroid gland. It increases the effectiveness to radioactive iodine treatment. Therefore, euthyroidism is essential prior to surgery and radioactive iodine treatment. Now, the next indication of thiamides is that they are useful in thyroid storm and thyrotoxic crisis. So, it is an emergency condition, it is an extreme form of hyperthyroidism. There is sudden surge in the levels of T3, T4 levels, increasing the T3, T4 levels, and it is triggered by infection, trauma, surgery, and sudden withdrawal of antithyroid drugs. It is characterized by cardiovascular signs and symptoms such as hypertension, tachycardia, arrhythmias, and also CNS manifestations such as agitation, delirium, confusion, and if left untreated can lead to coma and death. So this is a life-threatening condition which needs to be treated, and the drug of choice for the management of thyrotoxic crisis is propylthiouracil because of its rapid onset of action compared to methimazole or carbimazole, and also because of its additional property to inhibit the conversion of T4 to T3. So propylthiouracil, because of the property to inhibit the conversion of T4 to T3 and because it has a rapid onset of action, is preferred over methimazole and carbimazole in acute setting of thyrotoxic crisis. We have discussed the therapeutic uses of thiamides. Let's now discuss the adverse effects of these drugs. Generally, these drugs are well tolerated, but they have few side effects. The first side effect is agranulocytosis, which is rare but a serious complication of thiamides, particularly propylthiouracil. The patient may present with fever, infection, sore throat, and therefore CBC count is essential, and if diagnosed with agranulocytosis, the discontinuation of drug is necessary. Leukopenia, thrombocytopenia may also occur, however they are rare instances. The second side effect is hepatotoxicity, which ranges ranges from mild liver enzyme elevation to severe hepatic injury, and this can manifest as cholestatic jaundice and severe hepatitis. So this is dose dependent and requires discontinuation of drug if hepatotoxicity is diagnosed. The next side effect is dermatologic reactions which manifest as rash and pruritus, urticaria. These are immune-mediated reactions occurs as a result of vasculitis and may be associated with these drugs. Gastrointestinal side effects such as nausea, vomiting, abdominal discomfort is seen. Taste disturbances and metallic taste is observed with methimazole. Teratogenic side effects of congenital defects are associated with methimazole because it is highly lipid soluble and crosses the plasma rapidly, and therefore propylthiouracil is the drug of choice in pregnancy in a hyperthyroid patient. Therefore, propylthiouracil, because of its low teratogenic potential, is preferred in the first trimester of pregnancy in a thyrotoxic patient. In this lecture, we have discussed the therapeutic uses and adverse effects of thioamides. If you find this video useful, please like and share and subscribe. Thank you for watching.